androstenedione and why it's important in functional medicine and HRT patients. Androstenedione is one surprisingly reversible enzymatic step before testosterone. That's right, testosterone can actually convert backwards into androstenedione. By monitoring the androstenedione levels in the HRT patients, you can ensure serum concentrations of testosterone are steady without high peaks or valleys. HRT patients who have a high androstenedione level indicate a backwards conversion from the initial dose of testosterone. This means that either the ester of the testosterone has broken down too quickly or the initial dose is too large, and the patient may be better served by breaking it into two doses. Tracking the serum androstenedione level to testosterone ratio indicates the hormonal pathway is not being overloaded from high peaks in serum concentration. Testosterone therapy overall creates a shutdown, but not at the androstenedione level due to this reversible enzymatic transition, but at the actual unconjugated DHEA level, which can be seen by monitoring serum DHEA levels instead of merely DHEA sulfate. One of the unique properties of this is being able to look at how the hormones move between the pathway. If you look at androstenedione, it is converted either into testosterone or estrone. You can almost think of androstenedione as the gateway to its next step. It's a binary decision between what's going to happen in the sex steroid pathway. Typically, E1 or estrone is higher in postmenopausal women due to the loss of estradiol being produced. Furthermore, men receiving testosterone should look at their estrone ratio and not just estradiol because of the high serum concentrations. The testosterone can convert backwards into androstenedione and then into estrone, raising estrone levels without typically raising estradiol levels. Furthermore, testosterone has got two endpoints to its conversion. It will either be aromatized into estradiol or 5-alpha reductase is going to convert it into DHT. So to have a better overview and better possible outcome from testosterone therapy, you should look at DHEA, androstenedione. You should fractionate the estrogens so that you can see both E1 and E2 metabolites as well as DHT. This gives an over-encompassing view of the impact of hormone replacement therapy. So tips to improve patient care. First, all of your hormones should be quantitated by LC-MS. Request that you get androstenedione, the unconjugated DHEA, estrone, and estradiol measured in your serum testosterone, and this should be done periodically and regularly. Next, you want to be able to look at both your E1, E2, or your estrone-estradiol ratio to see which one is dominant. Next, you want to look at your androstenedione to testosterone ratio, and this will give you an indication if testosterone is properly moving forward in the pathway or is it overloading at that step and being converted into androstenedione. If you see high levels, a more frequent dosing with a lower dose instead of 1 mil per week or 200 milligrams per week, a dose of 100 milligrams twice a week would prevent the pathway from being overloaded and allow it to move through its normal steps. Next, if you look at your DHEA, what we found across the board is that many patients end up with a low DHEA levels. Supplementing with 25 milligrams of DHEA is a supplement in the morning on patients that HRT can bring their adrenal levels up of DHEA and improve overall therapy in the process. However, it's still important to monitor the estrone as androstenedione can convert into estrone. And now you've got one more step and one more piece to improve your outcome with testosterone replacement therapy.